Good afternoon and welcome to everyone. I'm really excited about this afternoon's webinar on the data exchange framework. CSAC, we're really happy to facilitate today's discussion and presentation. We have two representatives here from the Center for Data Insights and Innovation, or CDII, to provide a more county-focused discussion, on the data exchange framework. What is it? What's required? What's not? I really want to, thank all of you who responded to our informal survey, on whether or not there was interest on learning a little bit more about what's all, involved with the data exchange framework. Just at a high level, the data exchange framework was established through, implementing budget trailer bill language in 2021. It was Assembly Bill 133. I think maybe, that's all that needs to be said so we can, have time for the presentation. Just briefly, just introduce myself at CSAC. My name is Jolie Onodera. I am the Senior Legislative Advocate over Health and Behavioral Health here at CSAC. Also want to give a shout out to Michael Sweet, who is not on camera, but behind the scenes. He does all of our very cool video and all of these projects for us. And then I also want to introduce Danielle Bradley, who is our legislative analyst over health, human services, and homelessness issues here at CSAC. And really with that, I think I'd just like to turn it over to Deanne McCallan and Rem Cothran.
Hi, everyone. Hi, thank you, Jolie. Thank you for having us today. So I'm Deanne McCallan with CDII, Deputy Director for the Data Exchange Framework. And later in the presentation, my colleague, we call him RIM, R-I-M. He is Dr. Robert Cothran. So RIM and I go back 10 years or so, long before AB 133 and the Data Exchange Framework, working on HIP. So RIM is a health information exchange consultant, a subject matter expert in this field. So I'm always pleased to have RIM help support me present what we're talking about and what we work on in the Data Exchange Framework. So overview of what our deck, which we will be sharing today, Jolie will share it with you all, is an overview of the Data Exchange Framework. You'll hear me flip into acronym land and call it DXF. Who must participate, how to participate, and some information about grant programs, and then they're more specific and focused on the Data Exchange Framework and counties. This is who we are. You saw us before. We'll go on. And you'll see us both while we're talking today. Overview of the DXF. So the vision for the data exchange. Jolie touched on it a little bit, but within AB 133 from the summer of 2021, which was via trailer bill, established the data exchange framework. And the vision behind it is that it will create new connections and efficiencies between health and social service providers, improving whole person care. There is a relationship to data exchange framework in CalAIM, but we are not limited to just the Medi-Cal space of payers, which CalAIM is pretty focused on, I believe. But when one opens up and looks at the actual original legislation of AB 133, I think it's about 400 pages, and about 6 pages within there is what established the data exchange framework. It is the first ever statewide data sharing agreement that requires the secure and appropriate exchange of health and human services information to enable providers to work together and improve an individual's health and well-being. So it's really a vehicle to accelerate and level up the exchange of health information in California from where it's been. So especially on the health side, there's been a lot of investment federally and both in the state over the past decade. But now this is also bringing in the social services sector and trying to get to the whole person care. Next slide. So what is the data exchange framework? I even have an email from internal within our department within the agency about from 30 minutes ago or so with some questions, more from like our IT backbone, asking some questions about the framework and the technology and the infrastructure. It's not that. The framework is actually the rules of the road, providing the governance, the policies, how to take that vision and get it going, but it's not an actual database. It's not a repository. It's not a specific or prescriptive technology that anyone must use. Rules of the road. So before the data exchange framework, so where they're siloed and fragmented systems and sectors. So we do still live in this space today. The timing of AB 133 in the summer of 2021 is also related to the COVID experience. So we all know the first year of COVID on data sharing, data access, being individual patients or providers knowing about who somebody's vaccine was. We definitely, the silos were accentuated because of the pandemic. And yet there's silos that we've all seen and known for a long time, such as behavioral health. The value of knowing an individual's housing situation or their inability, their lack of access to housing, connecting the correction system and jails and prisons to successful reentry back into society and bringing along, trying to keep folks who are coming out ideally healthy, keeping them healthy and incorporating into the system. So public health, labs, pharmacies, hospitals, getting it all instead of multiple, let's try to clean it up. So the next slide is what the vision hopes to clean it up for after the data exchange framework or during it. So with patient-centered, individual-centered, they're not always patients. They might be someone who is utilizing social services in the state, but when they do present for clinical and as a patient, let's have it be a much cleaner, seamless, connected system. So this is one of the goals of where we'd like to go, cleaning up the web of duplication of effort, reducing the cost of being able to provide better outcomes with the level of effort that we're all putting into everything. And I also I call out the community-based organizations for CBOs. Every now and again, I'll catch an acronym and want to make sure we all know what the terminology is. What the statute actually put into legislation, and we have a couple excerpts from that, from the legislation, was that the framework would be created that included a single statewide data sharing agreement and policies and procedures that would support the DSA. So we call the data sharing agreement the DSA. We have not done this alone. It has not been CDII working in isolation. It's been a stakeholder process since the beginning, since the original legislation listed out a long list of entities, not so much by name in the actual legislation, but the type of entities that needed to be included in an advisory group. And then there's been subcommittees as such. And CSAC was also specifically called out in the statute to work with Cal HHS, who has put all responsibilities essentially on CDII as an office within Cal HHS to implement, to stand up the data exchange framework. So all along, it's been a stakeholder-driven process. And members of the public, we have open advisory group meetings, which have now become implementation advisory committee meetings. We publish public policies and procedures with a window for public comment and revisions, and then we give report outs and feedback, and then we create everything. So everything that we have been doing has been quite transparent, and a lot of people involved, a lot of entities, more than 600 members of the public and these different organizations have participated in our meetings. And there's still a lot of good engagement, and there's still plenty of people who hours like this is the first time they're hearing about the data exchange framework. That is not unusual at all either. So components, I just spoke a little bit about what there is a framework. We have a website that gives some bullet items of what the initial staging and setting up of the framework were involved, and some resources that folks can read that can be quite insightful and helpful. Data sharing agreement and common set of policies and procedures that spell out the standards for and governance of information exchange. And then another component of the regulation was that there be a strategy for digital identities. And those are that enables health and social service organizations to match shared individuals while keeping information private and identities secure. So my birth name is not Deanne. It's a nickname, and my health insurance name is different, and what other, this type of stuff. So just like, what is my digital identity? How does my information flow? So that's definitely a large part of the framework that needed to be considered and help the entities that are part of the framework know about. So those are the main parts of the framework, the components of. This deck should, when you receive it, link to the actual data sharing agreement, and then there are a number of policies and procedures. So the rules said to establish that CalHHS would establish a data exchange framework by July of 2022, with implementation and the exchange happening under the rules of the framework by January 31st, 2024 for many of the entities that are required to exchange. There's another subsequent deadline for entities that are not in that, who have a carve out based upon certain types. And then another component was to establish policies and procedures by July 2022. That does not mean every policy and procedure that we'll ever need is finished and completed and exists, but many were. The important ones to really stand up and support that initial framework were established by July 2022, and those are the ones on the left-hand side. So how to amend that single state data sharing agreement. How do we handle modifying policies and procedures into the future? How are breach notifications of if participants under the framework, if one of them has a breach, how is that handled? What are the permitted, required, and prohibited purposes? What is the requirement to exchange health and social services, privacy and security safeguards, individual access to services, and then data elements, and it's actually individual access to, I think, their information, and data elements to be exchanged. So what actually has to be exchanged? There's basically two. In my former role with the California Primary Care Association, was I really honed in on what were the requirements to exchange and what were the data elements. Like if I didn't have time to read all 8 of these, I was going to go on the benefit of the members I was helping to understand the data exchange framework, to hone in on a couple of them. None of these policies and procedures are that long. They're typically 2 to 5 pages long. So you might see a list of them and go, oh my gosh, somebody thinks I'm going to go read all of those, but collectively, they're not a massive like encyclopedia, aging myself a little bit there. And then we still have some policies and procedures in development. So one of the ones that was finalized last summer is under amendment right now. And then there's other ones that just simply, it was too early to stand them up before last summer. So information blocking, real-time exchange, technical requirements for exchange, a qualified health information organization program with more information on that coming up. So this is part of the transparency of just letting everybody know, and that what we have worked on, what is available for reading and learning, and what is under development, and even access to drafts of those documents as well. And then what does it mean to be a participant in the data exchange framework? Who, what do they do? What are their requirements? And while I'm talking, I'm not even looking at chat, but by the way, we encourage folks to fill it in, put questions in. We use the Q&A for submitting questions that we can try to answer while we're presenting today during this hour, and otherwise, hopefully at the end of the hour, we have time to talk through some of them. And the chat is where some resources are being dropped. So important dates of the data exchange framework. So I've talked a lot about what happened up through summer 2022. 2023, January 31st, all required entities who are called out in the bill, and we have a slide on that coming up, were to have signed the data sharing agreement. That is still a document that is open and available. It's through an online portal to sign. And even though the deadline is passed, we're working on educational activities. For an example, working with CSAC, providing information about the data sharing agreement. And we have 8 educational grantees that we work with who we lean upon, and we have that resource coming up in a subsequent slide. I think I am kind of mixing up some of the slide decks that we're presenting to folks, but we do have all this information. There's a signing portal. That's where folks actually go to sign the data sharing agreement. On our website, you can pull down, and there was a link on another slide to actually get the PDF of the data sharing agreement that you can read it. We have a grant program that opened up last week, and for a lot of you, you might not be eligible until round 3, but that's not so far off in the future. That could be late July or August at the latest is what we're expecting. We're launching the Qualified Health Information Organization program, and all of this is towards readiness for January 31st, of 2024, where many entities must begin sharing under the framework, and some entities have until January 31st, 2026. Who must sign? So the list in the blue here are the entities that are the entity types that are called out specifically in Health and Safety Code 130290, which is where AB 133 was codified. So general acute care hospitals, acute psychiatric hospitals, physician organizations and medical groups, skilled nursing facilities that currently maintain electronic health records, healthcare service plans and disability insurers, which include Medi-Cal managed care plans, and clinical laboratories. So there are 1, 2, 3, 4, 5, 6 entity types, and under those, there's a lot of, so a lot of people will ask us, how many entities or how many people or organizations must sign the DSA? The denominator is probably pretty big, because every acute care hospital in California, every acute psychiatric hospital, every skilled nursing facility, with the little caveat that maintains electronic records, and so on. And then next slide, please. And for a lot of you today's audience are probably what we couch and put in a bucket of encouraged signatories. So the words here on this slide that are in italics are exactly from AB 133 and are exactly in Health and Safety Code 130290. Cal HHS, appointed to CDII, shall work with, I'll say CSAC, to encourage the inclusion of county health, public health, and social services to the extent possible as part of the Cal HHS data exchange framework in order to assist both public and private entities to connect through uniform standards and policies. So this is directly from the regulation. And then the sentence that follows that in the same reg, it is the intent of the legislature that all state and local public health agencies will exchange electronic health information in real time with participating healthcare entities to protect and improve the health and well-being of Californians. So though the previous slide did not have state and local public health agencies listed, they're called out twice in the 5.5, 6 pages of AB 133 in these 2 sentences. So we do have more than 1,400 organizations who have signed the DSA, tying this to the list of the 6, and then the encouraged, and then we also call them another bucket of voluntary, are 900 plus ambulatory care facilities and practices, 130 hospitals, at least 80 long-term care facilities, at least 50 health plans, at least 50 clinical labs, 80 different voluntary community-based organizations, health information organizations, social services, and at least 50 county or county affiliated. The reason it says county affiliated is because this is information that is when the entity is signing the DSA in the signing portal, they use drop arrows to self-select their type of entity. The early signers didn't even have some of those, and they could leave it blank. I think they're now required to at least choose one level. There's a primary type and then a subtype you can select, but they self-identify. So some will look very much like a county, and then you look a little further in the details of like a subordinate entity name, and maybe it's a pharmacy. So that's where I mean county affiliated. If you see 50 plus counties, you might be like, well, we're almost done. There's 58 in the state, but they're county affiliated, and they're also self-identified. So we are working on making sure. One example is a county reached out recently because it was showing up that the individual name who had signed looked like that person, the individual, had signed as opposed to the county. So that's the type of stuff we also help with to clean up and clarify. We do have a website that lists exactly who. So it now essentially looks like a spreadsheet if you click on it. And that's what is available here says, and the website is posted recently. It was updated this Monday, and the figures up above, though, are from May 7th because it takes a little bit of filtering and pivot tabling to get those numbers that I didn't do that already since this Monday. Signing the DSA, this is a snapshot of what the signing portal looks like, where you will go to the signing portal, there's a URL for it, and once you're on it, there's also a help button up to the right that lets you be able to find some information, and we have more information on our website, so you can actually go to our website, CDII's website, and pull down the DSA, look at the FAQ, there's FAQs, there's other meetings and things that you could listen to on demand, take the, do it at 1.5 speed, maybe 2 times speed, and the list of signatories that I just mentioned. We do have, of course, always accept questions to our email address at cdii@chh.ca.gov. You can also email that and ask to be added to our list, our email list. So when we send updates, maybe we have a new policy and procedure that we've posted for public comment. Maybe we have a final policy and procedure that's just being posted. Maybe we're holding a grants town hall meeting or something like that. If you ask to be on our email list, then you'll get the notifications of that type of information. So how do you exchange? This is where we start to get a little bit more into the meat. So how do you exchange? So a qualified health information organization is also, so refer to them as a QHIO. I've heard some people call them a QHIO. We might also call them an intermediary because it might not be, there are other intermediaries besides QHIOs. But right now we're going to focus on some QHIOs, on the QHIO program, which the QHIO is specifically created for the data exchange framework. There's a national similar acronym of QHIN, a Qualified Health Information Network. They are similar, but they are different. So some people who are mindful and aware in the HIT space of QHINs will easily confuse a data exchange framework QHIO with a QHIN. But what they offer services and functions supporting the exchange of health and social services information. They have demonstrated specifically to CDII their ability to meet all data exchange framework requirements, and they provide technical and programmatic capabilities and enable data exchange framework participants to comply with their obligations under the DSA. Participants under the DSA in the data exchange framework are not required to use a QHIO, but we are here to say that because they're going through a fairly high level of scrutiny that is essentially a pass-fail model for checking all the boxes of whether they really can help anyone meet the data exchange framework requirements, this is why we want to do a bit of a spotlight on QHIOs. If you choose to use an intermediary to answer the how do I actually exchange, how do I get out of that silo that is very much in my county or very much in just who I'm familiar with. I already feel a little out of my silo. There's a lot of the participants here today whose names I don't recognize, which is great because there's a little bit of a redundancy of people who show up to our meetings and our webinars. Had that in the other spaces that I've worked in HIT over the years. So it's really great, little bit of a silo breaking down just when you see participant names you're not familiar with. But anyway, one way to exchange is through the QHIRs. They are required to earn that Q to have services that enable you to meet your data exchange framework requirements. They must share with each other. So California is, AB 133 in the data exchange framework specifically did not say California build one single statewide HIO. Some states in our country do have a single state-based health information exchange, and there's a lot of history in California of health information exchange organizations. There's community-based exchanges, regional, of the regional HIOs, things like that, that we didn't want to have to start from square one or make people change. So one of the components of being a Q is that you share with other Qs. And that's one of the big changes I've seen over the last couple of years is that the different HIOs are really working and collaborating together a lot. Same thing's happening with health plans. Health plans are really getting together and working and talking about sharing across within their niche of the market and the health system more than I've ever heard over the last decade or so. QHIOs must be able to share with nationwide networks when that's appropriate. So it's not just saying it's taking every information that's being shared under the framework and just broadcasting it out nationally, but when appropriate, and they must have that technical capability. HIOs also provide data and services beyond requirements of the data exchange framework that may be valuable to you. Notice that there's no Q here. I specifically did not put a Q here because that's not a requirement of Qs that they have services over and above being data exchange framework. But these HIOs, most of it have existed long before CDII even itself was created and definitely before the data exchange framework. So HIOs are companies that are out there and provide data and services that exceed data exchange framework. And we have QHIO onboarding grants that are one of our 2 data exchange framework signatory grant domains to aid in the use of using or onboarding to a QHIO. So those are some great reasons and opportunities as well for that. QHIOs would help you do actual exchange outside of any exchange that you might be doing today or get you to the next level or even starting if you're not exchanging at all. And catch me on time if I'm taking too long, Rim, what it means to be a signatory. You have access to key clinical and social services information from healthcare providers, plans, long-term care, labs, and other signatories. So notice those are some of the ones that crosswalk to the required signatories. You can be alerted to hospital and emergency department admissions and discharges for authorized individuals. You become a partner in sharing your key clinical and social services information with others to help coordinate care. So partnering is a great thing as well as coordinating care. And you share in the trust of this common data sharing agreement, policies and procedures that require everyone to share and protect data according to a common set of standards. Of all those stakeholders that I rambled on about a few minutes ago, it's really like everyone agrees with the intent and the need for having this data sharing. Where there's details or in some of the level of, like what exactly requirements does a QHIO have to have, but everybody really does agree in building this trust and requiring everyone to follow a common set of standards because they know it will help break down silos. And I've mentioned a time or two grant programs. There's a couple details that should help here. So this is the Education Services Grant, these entities, even if, let's see if I call out the American Academy of Pediatrics. So you might work at a county, you might have nothing to do with the Pediatric Academy, but they are a resource for working on the data exchange framework. We kind of note to my colleague Qua, or if she's even here and listening, I have a new slide that I totally forgot about that has the basically like microsites that each of these organizations has, like the multi-association initiative. They hold office hours. They even have some where there's legal experts on their office hours to help answer questions about the data exchange framework. And then there's one for local health departments, the county CHEAC, County Health Executives Association of California. So if you're seeing any messages from them about webinars and you haven't joined any, I would encourage or reach out to them specifically if you need more one-on-one help or have questions. So this initiative's been happening since January and it's scheduled through the rest of the year with all of these entities. And then we just launched last week the signatory grants part of the grants of the framework program. So signatories, so you must have signed the DSA to be eligible to apply. And you have two pathways where you can apply for grant funds. So one pathway is the Qualified Health Information Organization onboarding grant, which is why we spent some focus, some time spotlighting them, that if you are looking to onboard to a health information organization, there is funding available to help pay the way to get to that. There's this grant domain also has the assistance of the California Association of Health Information Exchanges, acting as a partner to CDII, assisting you with doing the actual grant, doing the application, the keystroking, the data entry, writing the narratives after a meeting with you one-on-one, or any of the applicants, that you would then have to sign off on, of course. Like, they don't just submit an application on your behalf blindly, and the funding goes straight to the QHIO as well, which people requested when we had listening sessions last fall, because they also didn't want to get mired into the financial part of it. So there's the fiscal component of funneling the money right to the end user that's needed, that's being leaned upon to help you adhere to the rules and be able to actually exchange. So that's where the QHIO receives and manages the grant fund. And then there's another one, a technical assistance grant. So maybe you have been on a health information organization for a few years, yet you still haven't really implemented the workflows and you're not maximizing that. So then you could go technical assistance. Maybe, I know you're all probably not, but maybe you're one of those skilled nursing facilities who's just ready to go electronic, and they could really use some technical assistance funds to be able to become be able to exchange information. So you can build your own path, you do your own application, you get the money. Maybe you have somebody on staff that would already be able to help you get that way, but you just can't fund their time for that. So that could be one where you can actually apply for that through the technical assistance grant. So we have a couple different options here for the way to build and submit for grants to help support the implementation readiness for data exchange framework. So who qualifies for applying for a grant? So we have 3 rounds at the very least. We could have more. Round 1 is currently open. It's only been open for a week. They're short, somewhat accelerated grant application windows, 4 weeks, maybe some will be 6 weeks. So round 1 is open right now. And round 1 is for required signatories, because those signatories, most of them have the January 31st, 2024. So when you're in the actual application, you're self-selecting your signatory type. And if you select any of the ones that in this screenshot has a check mark on it, that means you're saying you're a required signatory, therefore you're eligible in round 1 or 2. If you select county or other, very, very likely you're not eligible until round 3. So that's where checking, maybe you check skilled nursing facility and we look at your application and see that you're not that at all. I saw some of that type of stuff in COVID applications for support and things like that, or for access to the vaccines, whereas nobody was doing anything untoward, but they were just self-identifying. They're like, I'm a community health center, but they were really a CBO type of thing. So we might see some things like that. Nothing would be punitive. We would probably just do outreach and say, you look like you might be a better fit for round 3. And then it'll be helpful to know if the grantees, the applicants, need to be ready for exchange by January 24 or 26. And if you don't know, that's okay. We'll help you find that out. So this is trying to drill down pretty tightly, and you must have signed the DSA. So who qualifies? Rounds 1 and 2, it's required signatories, and then county and voluntary signatories are eligible to apply in round 3. How much is ready? How much is available? So I'm going to focus in on counties. So baseline funding is $25,000 per signatory. So you might be an umbrella organization. You might be a parent organization for your county and have listed 10 subordinates in your data sharing agreement. That means there's 10 different entities that are potentially eligible for $25,000. And enhanced funding is based on, in this sense, you would get higher weighted if you serve underserved communities. And CalHOP was a predecessor to our onboarding grant that was funded through federal and state funding from via DHCS, Department of Healthcare Services, for health information onboarding programs. So if you were not in that program, you might be eligible for enhanced funding, and for counties that would take that up to $50,000 per signatory. We have an application guidance and a template. So if you're interested and you want to start looking at what I need to do to apply, the template is 12 pages and it shows every question that is in the grant portal. And then the guidance document goes into detail about some of the slides and stuff that I've been talking about here. That's about 40 pages long, but it does have a lot of information on it. And these resources and links to it are all available. And with that, I'm going to pass it to Rim, and then I'll start looking at the questions that have been going in the chat. And there you go, Rim.
Great, thank you, Deanne. And there's really one question out in the chat for you right now about dates for round 1 and round 2 that you might take a look at. So I'm going to talk a little bit about some of the aspects of the DXF that might be specific to counties. I suspect that this may create some questions too, and hopefully we've left some time here for us to answer some of those. So first of all, what is the impact or the potential impact to counties? I would hope that most organizations, even those that are required to sign the DSA and required to participate, look at this as an opportunity to have better access to data. All healthcare providers and plans must participate in the DXF must share key clinical data and notifications with all other authorized participants. And so that includes counties. If you are a signatory and participate, then that means that you have access to that key clinical information and may have access to notifications such as admissions or discharges from acute care settings or emergency departments. Dan noted already, one of the key policies and procedures are the permitted, required, and prohibited purposes for exchange. Public health activities are included in a required purpose, which means that all participants are required to support public health purposes in real time as required by the data exchange framework. The DXF establishes a common set of standards for digital identities and person matching. That means that we have better access to technologies and standards that will help us associate the correct real data with the correct real person across many systems and many care settings. And so that becomes an advantage to all of the participants. QHIOs, as Deanne has described, may help all participants, including counties, meet requirements. And this may be an opportunity for organizations that have electronic information, but perhaps not housed in systems that are capable of the modern exchange technologies that are required by most settings today to actually exchange their data. Well, QHIOs or other intermediaries can help with that. And although most of the focus, especially on mandatory signatories, has been on the healthcare setting, social services and social determinants information are to be included in the data exchange framework as well. So that means that key social determinants may soon be data elements included in the data exchange framework. Often questions about legal aspects or considerations of the data exchange framework and privacy considerations. There is nothing in the data sharing agreement or any of the policies and procedures that overrides current requirements for public health reporting. Current standards and methods remain, but may be enhanced by new real-time sharing requirements under the data exchange framework. Again, making it potential to get more timely responses and more timely access to clinical information. The data exchange framework does not require sharing data in any way that is not allowed under applicable federal, state, or local regulation. That means that current protections for individual privacy are still in place, that if patient consent is required in order to share information, it is still required under the DXF to share information, and individuals may still decline to have their data shared just as they can today. There is nothing in the data exchange framework that overrides any of that applicable law. On the other hand, the HIPAA privacy standards and security safeguards become the floor for most DXF participants, even if they are not bound by HIPAA. That means that, for instance, social services organizations that choose to participate, they are voluntary, but if they choose to participate, they must protect the privacy of information and secure the data in the same way that healthcare organizations do under the HIPAA privacy rule and security rules. It becomes the floor that all organizations must adopt and helps set a standard of trust among organizations and with the patients and clients that they serve. And really importantly, the DSA is a common data sharing agreement that everybody signs. They don't sign their own version of it. There are no red lines to that. Everybody agrees to the exact same terms and conditions. And this gives us a a common set basis for trust in sharing data with each other, but this does not replace a BAA or a business associate agreement for organizations that have a business associate relationship with each other. However, most DXF exchanges between organizations are not as business associates and do not establish a business associate relationship. So a BAA is usually not required. This is something that you're just going to need to take a look at. If you use an intermediary, a BAA is probably required, but exchanging data with plans, healthcare organizations, physician organizations, clinical labs, etc., likely do not require a BAA. So what are the responsibilities of local health jurisdictions? And there are just a few things that I want to touch on here. First, some counties may have departments or programs or services that are mandatory participants in the data exchange framework. Now, Dan already talked about what those organizations are, but if you operate a general acute hospital, an acute psychiatric hospital, a clinical lab as it's defined in AB 133, or a healthcare insurance plan or a Medi-Cal managed care plan, then those programs at least are mandatory signatories, must sign the DSA, and are eligible in round 1 grants to participate. Counties per se are not mandatory signatories. However, AB 133 was clear that the legislative intent was that all state and local public health agencies will exchange electronic health information in real time with participating healthcare entities. And so the legislative intent for local health jurisdictions to share data in real time was made clear. And then finally, the DXF exchange all participants to share data following the U.S. Core Data for Interoperability or U.S. CDII standards. This is a federal standard that establishes a core set of data that's considered important to facilitate care coordination. It includes information about patients, their medications, allergies, immunizations, problems, care plans, etc., and recently was expanded to include certain social determinants information as well. These establish a common set of data elements and terminologies, a common language per se, that all participants use on the data exchange framework, and establish the floor of elements that as a signatory, your county would be required to share. In particular, you can look at the data elements to be exchanged, policy and procedure for more information on what those data elements are. This is kind of a summary of other information that may be available to you. I dropped some of the website information into the chat if people saw it there, and many of the links are on the slides here when that's distributed. In particular, there are also upcoming meetings. We have a regular webinar series that we call Information is Power. You can find information on upcoming webinars on our website, and also public meetings such as the Implementation Advisory Committee and DSA and P&P subcommittee meeting that's coming up on June 5th, where we'll be talking about some of the new policies and procedures and progress in the QHIO program. And then finally here, you can always ask questions or join our mailing list by mailing us at cdii@chhs.ca.gov.
All right, Julie, it's 4:28.
Wow, excellent timing.
That went fast.
Well, yeah, no, and you answered all of the Q&A. One, I just really want to thank you both, Deanne and Rim, today for spending the time with all of us and for providing your expertise on this issue. I know you two have been deeply involved in this issue for quite some time, and really do appreciate you taking the time to answer questions as well. For those of you on, I just want to say, yes, we will be providing a link to a recording of this along with a copy of the slide deck. And in that slide deck, there's just so much good information and resources there for follow-up. And with that, we are at 4:29. I want to thank everybody, and everyone have a great afternoon.